So I'm presenting an interesting case today, sir. There was a complication during the procedure because the challenge I had realized before starting the procedure. I was taking due precautions, and with the OCT guidance and presence of mind, I could appreciate the complication early, and with the positive outcome. The patient is stable now, sir. He has completed 8 months of follow-up. So this is a ostial LMCA dissection, guide induced, and this I will be presenting how I address these complications. So my patient details are: he is a 54-year-old male, non-diabetic but smoker. He had presented initially in a peripheral hospital in J&K with inferior wall MI on 2nd of August. He was lysed with nictoplase with window period of 3.5 hours there, and ST had resolved post lysis completely. And patient was thereafter shifted to our hospital. He was air evacuated to us on 5th of August. He was air evacuated from 92 base hospital, Srinagar, sir, on 5th of August. So his echo on arrival was EF was 45%. He had inferior posterior wall kinetic, but thickness was preserved, and he had mild MR. So I took him for the angiography on the next day because he was pain-free on arrival, which revealed triple vessel disease. So in the first sitting, I addressed only culprit vessel on 6th itself, and 3 stents were implanted there from RCA to RPDA. And thereafter, he was taken up for the PCI to LED on second sitting on 12th of August. Sir. The challenge here, which I noticed before starting the case, was tortuous anatomy of the LED. Sir. So this was how the case was. Sir. This is the first I addressed the RCA. Sir. There were 3 blockages, so I addressed all 3. Sir. And Timothy flow was established. So after this, I did this angiogram, sir. For LED on 12th, I had taken EBU guide. I was taking due precautions because I realized this is a very tortuous anatomy. And so accordingly, sir, EBU guide was taken for better support. So I crossed with the whisper extra support wire, realizing that there must be a problem during negotiation of the hardware. So this mid to distal LED was now pre-dilated with the 2.5 into 15 balloon, sir. And thereafter proximal LED was also dilated with the same balloon. This was a semi-compliant balloon. So this was the result post-ballooning, sir. And after that, further, proximal lesion was further pre-dilated with the 2.75 into 15 NC balloon, sir. So thereafter, I could negotiate with little difficulty. The first stent that I chose was purposely I chose a Resolute Onyx stent because of better and it has got better profile for negotiation, sir. So it was stented with 2.75 into 36 millimeter drug-eluting stent. This time also I had difficulty in negotiating, sir, but with whisper extra support and EBU, I could track it, sir. And further, it was dilated with the stent balloon. Little I pulled a bit back and then I dilated the whole portion, sir, the stent balloon itself. And thereafter, this NC balloon post dilatation was also done for the stent distal part, which I thought that it has not expanded fully, sir. So after this, the problem started. Now I wanted to take the stent 3.5 into 30 again Onyx I had chosen. But however, this also could not cross despite the whisper extra support and EBU. So again, I used one body wire run through, so I chose. And thereafter, with the bend, I crossed it through the stent. And thereafter, proximal LED was further dilated with 3 into 12, despite this 2 wires and further pre-dilatation. The same stent could not be negotiated. This was not going, sir, despite the 2 wires and further pre-dilatation. So this time I had option to choose 2 smaller stents. So this is what I opted for, sir. So the first stent I deployed was 3 into 20. Again, there was difficulty, but I could cross it. So removed the second wire and deployed the stent, sir. And thereafter, another stent 3.5 into 12 regulating stent were deployed in the proximal LED. So patient was fine till now, and I thought I had addressed all the problem. But after I started pre-dilating the proximal stent 3.5, I noted hypotension, and at this same time I noted staining was there. Here, staining was also there. So I thought that since guide was going up and down, sir, because difficulty negotiating the second stent. So this must have caused dissection in the ostial part of the LED. So I started the inotropes and since I had suspected ostial LED dissection, so I quickly deployed the stent here. The second wire which I had taken, sir, I parked in the LCX and quickly identified the ostium of the LED and deployed a stent in the osteoporox LED. So after this, staining disappeared, sir, but hypotension persisted. So this time, since patient was little stable, he was not that restless, and so despite the disappearance of staining, there was hypotension. So I took a chance and took him for this thing, sir, OCT imaging. I had got OCT and IVUS both, sir, but I chose OCT here, sir. And when I was doing pullback, sir, again staining has started appearing, sir. I can see there is a staining here, sir. So this was the OCT finding, sir. You can see from distal to proximal, stent is well deployed here, sir. Although I had given very cautiously giving injection, sir, so dye is not cleared completely. I was not giving it with full force, but I could realize the complication as we come proximally, sir, to this part. We can see that this stent is there, sir, but here we can see at this 9 o'clock, 12 o'clock to 3 o'clock, sir, there is a intramural hematoma, which was there. So it was extending into the LMCA. So this was the finding to summarize, sir. There is intramural hematoma, sir, in this place, 12 o'clock to 3 or 4 o'clock. So in LMCA, we can't leave it, sir. We can see it here also. So I tried to cover it completely. So I deployed my plan was to deploy 4 into 23 stent from the ostial LMCA because it will keep on extending, sir, otherwise. So I plan to deploy it from the ostium itself to cover the entire part. Sir, but this is how happened since the guide was EBU, because I had taken initially for better support and not realizing that I will have to do ostium LMCA also. And secondly, the patient was very restless. So during deployment, final deployment, sir, the stent got pulled up a little bit. It came out, sir, during final deployment. As we can see, ostium is there. So this much portion has come out, sir. So this is the second complication which took place at that time, sir. Since the restless patient moved, some part of the deployed LMCA stent was left hanging in the aortic sinus. So EBU also got dehooked by this time, and wire was also lost. So while going to engaging the this thing EBU. So second bailout, I quickly changed the guide to JL, sir, and aligned with the ostial LMCA strut wherever the stent was there, strut was there, and toss is the wire, sir, and through the hanging strut with the run through wire. So this is how I crossed it, and sorry, BMW wire used it, and thereafter I opened it with the 2.5 into the strut. I opened with the 2.5 into 12 balloon, sir. That after this, I used 4 into 12 NC and crushed the exteriorized part of the stent, sir, which was hanging there. No? It was crushed. It was here. So I got crushed and I created some new ostia, which was now stented with the another 4 into 12 drug-eluting stent to make it a new ostia. So we can see here the crushed stent is lying here, sir. This around 4-5 portion is there. And this is, I'm deploying a stent to the new ostia. So after this, I post-dilated the stent, sir, and the new ostial fairing was also done with 4.5 into 12 NC. And this was the final result, sir, I can see. Since I was very restless, I convinced him early for check angio after 3 months. So everything was fine till now, sir. And this time also I did the OCT also. There was some, in the overlap portion, I saw that there can be some, this portion is not, because there were 2 layers of strut here. No, sir. So this is the summarize the this OCT findings. Sir. We can see good MLS and we can see the crushed part of the stents outside, sir. Because of lack of time, I am skipping the video, sir. So this patient has completed 8 months of follow-up uneventfully. Echo findings, EF has improved to 50-55%, and TMT at 6 months is negative now, sir. My plan is to do check angio after 1 year. So take home message from my case is guide induced dissection are preventable by avoiding the deep engagement of the guide. Proper guide selection is very important. And if I had chosen JL for the this patient, so I may not have encountered the second complication at least. So switch to femoral in case of a restless patient, and never lose a patience and never lose wire in case of complication. And deploy stent finally can also be crushed and new OCT can be created as demonstrated in my case. And this patient has completed 8 months of follow-up. And intravascular imaging, if available, is extremely useful as it helps in picking up the first complication, that is that is LMCA, intramural hematoma. So thank you, sir. That's all from my side.
Yeah, thank you, Dr. Monga. So it was a good case, and mainly I think there were some complications, but you managed it quite well in the end. There are a few discussion points which we are going to discuss. So Dr. SP Singh, we called him as a discussant for this, and Dr. Jai Bharat has also joined. He had some emergency, I think, but he's now with us. Dr. Jai Bharat, there?
Hello, good evening, sir. Yes, sir.
Yeah. So first, I'll take your comments and your points if you want to give some inputs.
Yes, it's a very well managed case. I just if anchor balloon was tried or not, because we already had a distress stent in place. Anchor balloon could have negotiated well, probably. That is one way we often use, or the use of the guide extensions is one thing probably which could have hastened the process, and maybe the complication could have been avoided. But rest, otherwise, it was very well managed. And I should congratulate sir for such wonderful presentation of imaging as well. Thank you.
Dr. SP?
Can I answer in the meantime?
Yeah, please.
Sir, anchor balloon I didn't try, sir, but I tried the guideline, sir. But I was going through radial route, and it was 2 wires were there, so it was not going, sir, easily from 6 francs. What is your experience, sir? I didn't find it was not going, sir, that guide extension, sir, with the 2 wires in place, sir. So I had to remove the second wire if I had to take this guide extension 2/6F.
Yeah, that point well taken, that it was difficult with the anchoring catheter also. So Dr. SP?
Yeah, sir, this is definitely very well managed case, sir. So it usually happens with the deep inciting catheter. So most of the time, and sometimes I also suffered the same problem. That because of the deep hooking up the catheter, patient suffered the dissection, and finally we had to deploy the stent. So well managed and well treated the case.
Thank you, sir.
Yeah, so I think overall it was a tough tortuous vessel, and at times, it's difficult to maneuver stents down. You were going all okay until a certain point that contrast started appearing extravasating into the intima. So
Yes,
it was one I think we should also keep should be very vigilant. If that contrast is expanding, if that contrast is stationary at one point, that is one area which tells you that it's an intramural hematoma. So if the contrast, in your case, it was quite stagnant. So
yes,
at one point, so it was clear that some intramurally collection has happened, and that is stagnant at one point. And then you did the right thing by putting another stent to cover that. Now, after that, you have done a OCT, which tells us that some intramural is coming a few millimeters out of the stented segment.
yes, sir.
It was not a long length out of the stented segment, and there was no connection with the vessel. So the generation of that point was taken care of by another stent, the entry point.
Yes, sir.
And then there is some intramural. Usually they seal off.
So we can leave it, sir.
They are not
even left LMCA.
even yes. Okay. Because see the dynamics. It got started at some point where dissection happened. There was an entry point, and some collection went on backwards, retrogressive, towards the left main into the intramural, but there is no collection now. So once you have stopped the entry point, this hematoma will get absorbed with time and nothing would happen. So that is one point which I thought differently, that once we are sure on OCT that there is no other entry point, there is no active dissection, there is no flap, then we might have left it there.
Okay, sir.
Probably given a situation, I might have taken a call that leave it there.
True, sir. We have seen
I come
that.
in for a second.
Yeah.
I think there were two things very important why you needed to intervene in that case. It is said that if the TIMI flow goes down, or if you have hemodynamic instability, so you had hemodynamic instability and you needed to intervene, and you did the right thing, because your blood pressures went down despite doing everything. You were patient had hypertension.
No, Suresh,
I think if you have
I
hemodynamic instability and the TIMI flow goes down, you need to intervene. You cannot leave it on.
We don't know whether TIMI flow went down with that or not, because
I was saying these are two situations.
Hold on. Yeah, I agree.
Instability and the patient's blood pressure goes down, that you have to use inotropic support. You need to do something. That means this lesion was definitely giving him problems.
No. We don't know whether that's because of this, because once you have done a OCT, the flow was very brisk. There was no decrease in the flow, and the OCT looks clean. So if this was the lesion, intramural hemorrhage, see, it happened prior to that stent, which you put as extension. So that time hypotension happened, and maybe this was reducing the flow into the LED, and which you covered. So I think.
But hypertension persisted, sir, despite covering the stent. So that's why I did the OCT. Because hypertension was still persistent.
But then that's, see, I think at times, once this vicious cycle comes, it takes time to go also, to resolve also. So
but I had few dissections in the past also, and they immediately resolved after this dissected part was stented, flow improved. So it used to appear BP should improve immediately, sir.
After the left main stent.
Before left main intervention, sir. BP was not improving, sir, despite.
No. So that dissection, that intramural hematoma was the cause of decreased flow into the LED, and that resulted hypertension.
Absolutely.
I think that extension of a stent in the LED was definitely on the cards, and you did the absolute right thing. I am talking one step ahead. I am talking after that, once you decided for stenting into the left main. I am talking probably if situation was better, hemodynamics was improved, and flow was brisk, and your OCT was not showing any active flap. So then at that point of time, maybe many operators, I would probably, if things are stable, things are not going out of control, then probably leave it there. These things heal. If there are no connection and you have stented the entry point, they would heal. So this is one, but otherwise, given the thing that you stented, it's a operator's call at that point. I understand that, and you have done a fair decision of going ahead to left main, and then something happened. Obviously, you yourself mentioned one should not lose a wire, guiding, all these things are very important. Once you lose that, we know that a trouble starts brewing up and starts escalating further. But then by taking JL, crushing that stent, so it was whole spiral which you went through, but ultimately well handled, ultimately very well handled. I'm just saying how it could have been different. That's what my point is.
So can I share a few transradial points?
Yes.
Transradial points with them. There was while you were discussing your take-home message, you said you had written, one of the points was that you should shift femoral. I don't think we should shift femoral. You should shift to the route which you are more conversant with. So there are people who are like me. I am a completely transradialist. If you're doing transradial procedures yourself, and you contemplate to do export runs, you want to take more hardware, never ever take an Oxford catheter inside your radial. A 6F radial, transradial New York catheter will take 2 balloons easily. This is what we do. If you put an Oxford catheter, you will not be able to, be very gritty from inside. You will have a lot of problems. And if you're doing a case like osteal LED hair, like this, which we're planning, it will take, sometimes you will land in problems. You should use a 7F. Why use a 6F? And you can easily use a 7F sheathless without using a sheath. And it is very easy. It will make your life very easy later on. Because it's not that you go in with a 6F system and you can find the problem.
So Dr. Paul, this is quite well known. I think Point well taken, but I think we are short of time also. Let's keep going. It's already half an hour with the first case. But these are the points of discussion, yes, but all compliments to you, Dr. Monga, for this. So let's move on to the next case.